Welcome back. Today we're going to be talking about one of my favorite topics, metabolic dysfunction-associated steatotic liver disease, or MASLD, formerly known as non-alcoholic fatty liver disease, renamed to emphasize the metabolic component and the fact that many people drink small amounts of alcohol, and does that really count as non-alcoholic fatty liver disease? I'm diagnosing this in clinic all the time, even more common than diabetes, hypertension, and hyperlipidemia. MASLD is really important because it really reflects what we care about when we're treating our patients. Instead of just a number, it's all about preventing hard outcomes that matter to patients, cardiovascular outcomes, increased morbidity, mortality. So when we're talking about metabolic dysfunction associated steatotic liver disease, the question is, who do we screen for in the first place? Should we screen? How do we screen? And how often? Because your recommendations for lifestyle interventions are probably going to be the same whether they have it or not, the American guidelines don't recommend screening for metabolic dysfunction-associated liver disease. The European guidelines do, on the other hand, especially in the setting of metabolic comorbidities. This is going to include things like hypertension, hyperlipidemia, diabetes. Also think about obstructive sleep apnea and polycystic ovarian syndrome. It's really important to me because, for example, when we're treating a patient with hyperlipidemia, the AHA-ACC guidelines can be really rigid in terms of that 10-year risk. If you don't quite meet the cutoff, then maybe they don't need a statin when they really benefit from them. I find it tends to underestimate risk for certain people and maybe overestimate for others. So enter MASLD. If they've got that, especially if it's at an advanced, possibly fibrotic stage, then they might benefit even more from a statin. So that's going to push me into starting a statin, even if they're not quite at that 7.5% cutoff we frequently cite. So when we talk about screening for MASLD, usually you're thinking about it in somebody with diabetes, somebody with obesity, or other metabolic risk factors. So how do we do it? A lot of people think it's as simple as trending AST and ALT, or they'll add it on the comprehensive metabolic panel and tell me that they're screening for MASLD. But really, you need to use a validated test. The easiest one is the FIB-4 score, where there's cutoffs to determine the risk of liver disease. And if you have a low enough score, it's very unlikely that your patient has advanced chronic liver disease. It was originally developed for hepatitis C, and so the scores are a little bit different for MASLD, and I'll link to that in the show notes. Basically, if you get a low enough FIB-4, you're done. You probably don't have advanced chronic liver disease, and they don't need any further workup. If you've started down this route in the first place because you've seen hepatic steatosis on ultrasound, really important to counsel them on lifestyle interventions. However, if you get an intermediate or an advanced concerning FIB-4, that's where there's other tests that do come in. Proprietary tests from commercial labs, such as the FibroTest, FibroSHEAR, and HepaSHEAR can be helpful. Outside of the United States, there's also the ELF test that you'll see referenced in guidelines. And then beyond that, there's also transient elastography, which is measuring liver stiffness. If you do send somebody for a transient elastography test, commonly known as Fibroscan, and it comes back over 20 kilopascals, they'll probably benefit from a referral for surveillance of esophageal varices, as well as hepatocellular carcinoma. We talked a little bit about who you might consider screening for MASLD in the first place, but in terms of transaminitis, which is another route that this frequently comes up, the incidental bump in ALT or AST, how do we work that up in the first place? Obviously, the transaminitis workup is a huge lecture in and of itself. But basically, it starts with a thorough history, just like anything else. Are there drugs or alcohol that could be increasing ALT or AST? When you look at point-of-care resources, you'll frequently see a shotgun approach, if you will, to the lab workup for transaminitis. Some of them I rule out by history alone. The standard transaminitis workup would include thyroid dysfunction, since this can cause transaminitis, hemochromatosis. You'll also see alpha-1 antitrypsin deficiency and Wilson's disease, and sometimes celiac and maybe even autoimmune hepatitis. Autoimmune hepatitis is pretty rare, and patients are really sick, so I don't usually test for that. Celiac is also second or third line, so unless they have symptoms, I don't test for that as well. Regarding alpha-1 antitrypsin deficiency, that you can frequently rule out by history, asking about repeated respiratory tract infections as well as pancreatic insufficiency. We routinely order TSHs in primary care, probably overorder them. So if they haven't had one recently, I'll throw one on just because of the chance the thyroid dysfunction could be causing their transaminitis. Hemochromatosis is also a good one to rule out, but really I find that more often than not, I end up just catching iron deficiency anemia when I do screen for it. So once your conservative workup for transaminitis comes back negative, which it frequently does, in the presence of the metabolic risk factors such as obesity, hypertension, hyperlipidemia, and diabetes, you've probably been able to diagnose MASLD. So now that you've diagnosed MASLD, how are you going to treat your patient? We'll talk more about medications that we can use in MASLD, but generally the standard of care is diet and exercise. We want to encourage patients to lose weight because we know if they can get 10 to 15% weight loss, that will improve their liver disease. I usually recommend the Mediterranean diet, telling patients to avoid processed foods, simple carbohydrates, and whatnot, and to get as much plant-based food as they can. This is going to be beans and lentils, other legumes, nuts, fruits and veggies, and whole grains. I'll link to a handout that I usually give my patients in the show notes. If there is an indication for a GLP-1 receptor agonist, I do find myself prescribing those a lot. I'm very clear with patients that it's not approved for that. We only have preliminary studies. We don't have hard outcomes. But if there's another label indication, such as type 2 diabetes or obesity, then I think that these are great options for patients. There is a new approved medication for MASLD with fibrosis stage F2 or 3 in the absence of cirrhosis, and we'll talk about that in another video. But because it's so new, I'm not using it personally yet. In the next few videos, we'll be diving deeper into the guidelines and using sample patients as examples of who I might screen for MASLD, how I would stage them, when I might refer, and how I would treat them. In the meantime, I empower you to keep in mind the FIB4 and be purposeful about screening in the first place. It is a metabolic risk factor and can help in terms of deciding when you might initiate a statin and reinforce why the lifestyle counseling that you're giving is so important in the first place. When you're seeing patients with hypertension, diabetes, hyperlipidemia, don't forget about metabolic dysfunction-associated steatotic liver disease, or MASLD.